Good afternoon. Thanks for coming, guys. I think we're going to get started. So I'm going to kick it off. My name is Jim Min. I am a cardiologist by training and a cardiovascular imager. Like to think of myself as a clinical trialist and cardiovascular outcomes researcher as well. And now I'm with Cleerly. So I'm going to lead us off. I'm going to not take too much time, and then I'm going to turn it over to our esteemed guests here today. But let me just take 5-7 minutes or so to try to explain to you, at least, we conceived the idea of this thing a while back, and I just more want to share with you the rationale of what we were trying to make and why we were trying to make it that way. So without further ado, let me just go to the first slide. So around 20 years ago now, we started using CT angiography. We used CT initially mostly as a tool, like a non-invasive tool to better understand coronary artery disease. When I saw my first scan, it was a 4-slice CT scan, and I thought, this will fundamentally change our understanding of coronary vascular biology. So, for many years, we used this as a tool to really enroll patients into clinical trials, understand what we were looking at on the image, how that affected somebody's outcome, and how we could influence the natural history of that outcome in a favorable fashion. And obviously, this field, together, collectively, we've learned a lot over the last 2 decades. And based on what we had learned, about 12 years ago, my friend Erica Jones, you see her in the middle there, she and I started a program called Heart Health, really leveraging coronary CT angiography, similar to the way you'd use another non-invasive imaging tool for early detection of disease. What we then tried to do, we realized that this room here is a room full of experts that is in possession of a secret that most doctors don't know, right? We know so much about what we're seeing on that image, and what we realized was that the reports we were making were not conveying that information to clinicians in a way that, and it sort of robbed them of the most powerful aspects of that data. So we spent a lot of time educating our referrers, right? General cardiologists without imaging background, primary care physicians, and others. The third thing we did in that practice was that we empowered the patients with knowledge. And so we would sit there and go over every image with the patient, explaining what we saw. Once they saw their disease in their arteries, the compliance rates went through the roof. And so we thought that was a great way for us to engage with the patients. And then the fourth was, now that we were armed with this information about that individual's actual disease, we could personalize the care. So instead of relying upon surrogates or population-based risk factors, we could rely on actual disease, so we could treat somebody N of 1. And then finally, we do serial CTs really to track people quantitatively to make sure that what we were seeing was that we were stopping new disease from forming and that we were stabilizing pre-existing disease through the transformation of the non-calcified to the calcified plaques. And so that was like heart health. And over 7.5 years, we had about 4.5 cardiologists. We didn't see a single myocardial infarction. So we thought, this is working. It just is so manual, and we wanted to be able to scale it and to deliver it to any healthcare institution. And that's why we formed Cleerly. And so Cleerly was really intended not to be a test. It was not to be a metric. It was really meant to be a platform technology, really to try to establish a new standard of care for coronary artery disease. And so we wanted it to be all-in-one. And by all-in-one, and you can see the steps that we tried to define when we started the company was really exactly what we had done in clinical practice, just completely automated in a way that would leverage all of the technology tools to make sure that we could standardize care in a really good way. And we wanted it to be all-in-one. And by all-in-one, I mean in 3 different ways. The first is that we wanted to have every actionable coronary disease metric all-in-one. The second is that we wanted to hit every single stakeholder along the care continuum all-in-one. And the third was that we wanted a single platform that would use any user metrics. The user experience could have every kind of information that person would need all in a single setting. And so I'm not going to go in real detail because you're going to see actual cases from these guys. But let me just take you through this. The first software here is a software that we're very familiar with, imaging software, really to try to do end-to-end AI for atherosclerosis, for stenosis, for ischemia. but then to translate all of that into ways that clinicians who aren't familiar with the imaging can really understand, to be able to dive deep into this so that we can really help the patient, like use this as a teachable moment, to have the patient understand and be empowered by the data, and then to hit every single stakeholder, right? The preventive cardiologist for atherosclerosis, the general cardiologist for measures of stenosis, MLD, MLA, plaque length, things like that. To look at ischemia not as a yes but a yes and, right? So to take a tool where that you can do full comprehensive imaging, lesion by lesion segmentation, and really not only determine whether a vessel is ischemic, but also give you analogous information like diameter stenosis like QCA, plaque volume like IVUS, plaque length, minimum luminal diameter like OCT, and then lipid-rich plaque like a near-field infrared spectroscopy catheter. So really an all-in-one solution, lesion by lesion. And you can see I'm just clicking through each lesion, and you can get all of that information. And then for the imagers, like we wanted the CAD-RAD score, so that also comes out. For people like me who like to do research, I wanted the data. So at the patient vessel segment level, everything related to the coronary artery, everything related to coronary artery disease, you can simply download it as an Excel spreadsheet and just start doing research. You don't have to manually curate any data. And then everybody wanted a report. So this is a fully editable, fully customizable report, automatically generated and according to the FSCCT guidelines. Turns out everybody hates this report because they say it's like, I don't really understand what I'm looking for. And so we also generate a clinician-friendly report, a one-pager that really goes through plaque, stenosis, ischemia, and so on. And then the color coding of this as red, yellow, and green really makes it easy for somebody to understand whether or not somebody's sick or not, and that is juxtaposed to auto-annotated imaging on a vessel-by-vessel level for atherosclerosis, stenosis, and ischemia. The patients weren't really empowered by that. They didn't really understand it, and so we also generate a patient-level report written at, I think, an 8th grade reading level to really try to help non-medical lay people understand what we're getting out of that image so that they can be empowered by that. And then to come up with a staging system that we did a couple of years back for coronary heart disease and atherosclerosis, in collaboration with the ACC to come up with a suggested treatment algorithm according to those coronary disease stages, and then finally to track those changes over time. So what you're seeing here is an interventional cardiologist came in 2020, had a total plaque volume about 260, went on a PCSK9 inhibitor. 3 years later, what we've seen is that he has no new progression of disease. But as importantly, what you're seeing is that all of that yellow non-calcified plaque is turning blue into calcified plaque. His non-calcified plaque is dropping by 80. His calcified plaque is increasing by 80. He's transforming his plaque from non-calcified to calcified. So we're really hitting both of those goals, stopping new disease progression and stabilizing pre-existing disease. So that's sort of the care pathway that we really intended. Now what I'm going to do is I'm going to turn it over to our guest speakers today so that they can help you understand better the data, as well as just how people use it in clinical practice from prevention to intervention. So it's my pleasure to introduce Dr. Maros Ferencik. He is a professor of medicine and radiology at OHSU, Oregon Health Sciences University, and the Knight Cardiovascular Institute. He's the section head of cardiovascular imaging, and about 18 hours later, he will be our new president of the Society of Cardiovascular CT. So, Maros.
Thank you, Jim, and enjoying your lunch. I'm going to talk about the assessment of coronary disease with one application, stenosis, ischemia, and plaque. These are my disclosures. When we see a patient in the clinic, we have a patient that presents and there's concern for coronary artery disease. We mostly see symptomatic patients in cardiology. They have chest pain or other symptoms, but more and more there is sort of focus on asymptomatic patients for the screening, risk factors, family history assessment. And for 30 to 40 years of cardiology and imaging field, we ask these two questions. Does this patient have ischemia in the order to stress test? Does the patient has obstructive coronary disease, send the patient to the cath lab. That sort of paradigm changed in guidelines in 2021, eventually recognized that change in the pattern, and coronary CTA got one class 1 indication, and it's now the first choice test for evaluation of patients with suspected coronary disease. So the most important change in the guidelines was actually the definition, how we define known coronary disease. And because we tested patients with stress tests, or we went to cath lab, and when there was maximum some irregularities, we told the patient it's all normal. Now we have CTA that shows actually the plaque. And it was the intent of the guidelines writers to actually make this change. They wanted to make sure that the patient that have coronary atherosclerosis do get the treatment and do get preventive treatment. So that paradigm completely changed. So now we have detection of non-obstructive disease as a major part of the guideline. Now, I would submit to you that the clinical questions are different, and Jim and Leslie and Jagat actually sort of coined this graph, which I had stolen from Jim, I believe, that we have this group of ischemia that we tested, the patients that have stenosis, but it's this large group of patients that has plaque that should be of our interest in coronary CTA field. In addition, we have different stakeholders. We have people on the left side, we have from patients through the general practitioners, general cardiologists, imagers, interventionalists, and those who care about the preventive care. So how can we, in CT, with the Cleerly CAD platform, help them to maintain their roles and get their goals, what they have? So we'll start with stenosis. This is our, that's why CTA was sort of developed back in early 2000s. And over time, we show that it has a really good sensitivity. Specificity is decent, comparable to other tests. And this is the large data set from Johanni Knuti, almost 30,000 patients. But we also have, in general, problem in imaging and in reporting, and these are data from Promise Trial from Michael Liu, showing that when you move from sort of just general practice when people read the studies, and you move to the core lab where really people are very organized and systematic, you decrease the amount of patients that have significant stenosis and detect better those who actually have worse outcomes. So can we replicate it in our day-to-day practice? And AI-QCT analysis, I think, help us to basically replicate that core lab situation, where you have your, all the components, you get your best series, you identify wall borders, central line, plaque, vessel, and quantify the stenosis as already Jim showed us. Of course, you need the data to show that this actually works. These are data from Andrew Choi and from Clarify study that show that when you have level 3 readers, you can actually improve your ability, or your correlation can be really excellent when you have this AI-QCT analysis. Of course, what you care is also how it compares to your gold standard. And these are data from the Credence that on the left-hand side show that AUC values and sensitivity and specificity for the quantitation of stenosis, AI-QCT versus quantitative invasive coronary angiography is very, very, very good. Ultimately, you are comparing to FFR as a measure of hemodynamic significance, and the data there are also very good for AI-QCT. Once you have the data, we already talked about it, you want to get them very quickly to the reports. And Cleerly, a CAD platform allows you to get the results from AI-QCT data very conveniently to your report. So when you have us cardiac imagers here that report coronary CTA, we can do our analysis relatively easily and rapidly, and we can increase our reproducibility and get it to our reports very quickly. We already talked about the reports being not only on the left-hand side for the readers, but have a report for those who report, to refer patients to us, to make it easier for them to understand, and to patient as well. Again, fulfilling the other goals of our reporting of coronary CTA. For the patient, they can clearly understand what the diagnosis is. So with that patient report, they can understand what the results are. For those who referred us, they have a clear report. And for us in the practice, it makes it easier to report it. Of course, we now understand that ischemia detection is even more, or hemodynamic significance, we can call it, is even more and more important. The reason for it is when you look at the same Johannes Knuti's data, when you compare us actually to invasive FFR, for the specificity, we sort of suck, and we always knew it. So we knew we need a solution for this problem. And the reason why we need a solution to this problem, because we know that it matters. And FAME2 and FAME studies and other studies in the field showed us that if you revascularize, if you relieve ischemia or hemodynamically significant stenosis, that's where you get improvement in outcomes over time. So the response of a Cleerly ISCTQ ischemia algorithm is to use the AI machine learning, take the measurements from atherosclerosis, stenosis, and vascular morphology, and put it on a model on vessel basis. You basically can determine what is the high likelihood having of abnormal invasive FFRCT. You have a binary output both on the vessel level. Of course, you can sort of put it together for patient. And as you can see, there are measures from the stenosis or vascular morphology, as well as atherosclerotic measures that contribute to this algorithm and eventually AI ischemia classifications. And I'm not going to belabor this because we already saw it. You basically can determine whether the vessel is ischemic or not. Of course, what we want to talk about are the data that support this. And the data were derived from Credence trial. So Credence trial that you're familiar with is in derivation cohort of 307 patients. The data were derived, and it was then validated in the Credence cohort. And this was taken out to another population of Pacific 1 to actually validate it in the external data set. The results from the Credence, and this is the validation cohort of Credence, not the derivation, that's the validation is that second half of Credence. You can see it both per patient and per vessel. We are getting sort of 85, 77, 56, 62 respectively for sensitivity and specificity, and very good AUC values. Then when we take it to Pacific 1, the numbers are actually even slightly better, which is really reassuring because we are showing that in an independent population of patients, this algorithm still works. Now, we have also now data from practice. We have data from Cedars-Sinai on a small data set of 35 patients showing very similar data of the AI-QCT ischemia for detection of invasive ischemia by FFR or IFR, and similar from the Scripps Clinic, again showing that the sensitivity and specificity values as well as overall ICU are really holding in these other independent populations. When you apply it in your practice, you want to see how it actually works, how it changes what you do. And certain studies sort of aimed to do that. In a 750 patients, pretty expert areas. This was in a pretty good 5 centers. We asked they asked the docs, what would you do once you have the results from IAQ-CT analysis? Is both the quantitative assessment as well as ischemia, as you can across the different areas of additional need for imaging, CAD RADs, interventional medication plan, plaque assessment, all sort of higher sort of fidelity in your results. They also ask about what you would do, and as you can see, you would do 37% less testing, and you better assign patients actually to those who need PCR or CABG or not. Ultimately, you want to know what happens to the patient that had ischemia. Do we predict future cardiovascular events? And Pacific 1 actually has 8.5 years of data, and AI-QCT has shown to be eightfold increase, abnormal AI-QCT ischemia is associated with eightfold increase of major adverse cardiovascular events, again showing that AI-QCT ischemia is the strongest predictor of future cardiovascular event. And to be sure that it works in other cohorts as well, Turku study from Juhani Knuti and his group showed that similarly to Pacific 1, when you take AI-QCT ischemia, you have significantly increased risk of future cardiovascular events if AI-QCT ischemia is abnormal. Now, very interesting data from the Turku studies, like who are the patients that actually benefit from this test? And they actually observed that it's the patients that have non-obstructive disease and the patients that didn't get their revascularization. So we are selecting these patients that actually need probably further studies when you go back, further interventions, when you go back to the sort of overall philosophy of the FAME2 trial. So now we are fulfilling our other roles and goals with the CAD platform. For the patient management and those who take care of the patients, they can decide, do I cath these patients? Do I go and get medical treatment versus I send them to interventionalist? For our imagers, we get additional information to sort of make us sure that we are doing the right thing for the reporting. And for the interventionalist, hopefully they get the right patients to the cath lab. So the rates of obstructive coronary disease among those who are in the cath lab increases, and they can guide their interventions. Finally, we get to plaque, which is sort of my biggest interest has been. And why plaque? Well, I always use this slide from our work with Udo from PROMISE trial. When you look actually at numerically who has events in PROMISE trials, so more than half of the events occur in those patients who have non-obstructive disease. So those are those patients who you will not detect by stress testing at all. You don't know those patients are there. Those are the patients that will have the events, and we need to help those patients. And of course, that results in better performance of CTS compared to functional testing for the prediction of major adverse cardiovascular events. Now, the difference between 2013, 14, and now is that we know in the meantime that the quantitation is not only possible, but it's also very predictive. Munich cohort showed more than 10 years of follow-up, more plaque you have, higher the risk of events. Scott Hart showed low attenuation plaque, more risk of future cardiovascular events. So the response of Cleerly analysis for that is first to show that what you see is real. So you use the gold standard intravascular ultrasound to confirm that actually measurements that we get from coronary CTA are measuring what the gold standard is for intravascular imaging. Then there is importance of staging, and I'm not going to go in detail. Jim already said we have now the staging system based on the amount of atherosclerosis, so we can categorize patients in the broad categories, and we can see how this performs for future cardiovascular events. And as you can see, not only higher stages predict higher levels of major adverse cardiovascular events, most importantly, in each of the CAD/RADS categories, so everything what we do in the daily practice, say the patient has stenosis, mild, moderate stenosis, in each of those categories, more plaque you have, higher risk of cardiovascular events. The ultimate goal, I think, our ultimate role of the quantitative plaque imaging and characterization is our ability to actually discern what's happening to the plaque when you treat. And Alex is sitting there, his great work in paradigm trials showing that it's the need of quantitative plaque assessment to understand what happens to the plaque. Because when you treat a patient with statin and with other medications as well, you decrease amount of non-calcified plaque with low attenuation fibrofatty fat, and you increase the calcified plaque. So you fundamentally change the composition. And unless you have quantitative characterization of those features, you will not be able to understand these changes over time. And we have those examples. We already saw the example of patients that's treated a statin and stabilizes the plaque with calcium. You have here an example of somebody who doesn't take any medication decided and goes and progresses the plaque. And then we have example of our ultimate goal of the plaque regression. And with the all modern new therapies that we have, we are at the stage where actually we can probably regress the disease as shown in this example. Of course, the plaque data need to be transformed into usable reports, whether it's on the physician side or more importantly on the patient side, so we can get the most important change, and it's the change to quality of life and prevention of cardiovascular events for the individual patients. Of course, us who treat those patients, we will be guided by the results, by the detailed results, and hopefully allow patients to achieve what's the most important for them in their lives. So in conclusion, I would say that the Cleerly CAD platforms provide a bridge between what patients and all the physicians and providers need and what we have in the output from Cleerly CAD platform. Thank you for your attention.
Great, thanks so much, Maros. And then another congratulations to Maros, not only for assuming the presidency role tomorrow, but for being the ASM chair and for such a successful meeting. We're going to now turn to Dr. Victor Cheng. So Dr. Victor Cheng and I have known each other and been friends and colleagues now for too long, when we were young. But we met when we were at Cedars-Sinai, but we're doing research before that. What I think you'll see from his case review is how are we taking all of that science and implementing it in actual clinical practice, because that's ultimately why we're doing it. So I think for very pragmatic hands-on, I'd like to introduce Victor. He's the Director of Cardiovascular CT at the Minneapolis Heart Institute. Victor.
Yeah, thanks, Jim, and the event organizers for inviting me to present our experience at the Minneapolis Heart Institute with the Cleerly platform. I am part of the Scientific Advisory Board as my disclosure. So I'm just going to hit you in the face with numbers that we've accumulated. We started routinely sending unselected consecutive patients for Cleerly analysis the beginning of last year. And we do not adjust the contours that come out, the results that come out. We don't have time at our practice given the volume. And there on the top right, you can see we've sent to date, actually perhaps as of 2 weeks ago, we've sent over 6,000 cases of patients without stents or grafts, and 1% of the time the platform returns that they could not analyze the data. And it's almost unheard of for me to hear from my techs that a request has been asked for them to somehow reconstruct the data or reacquire images. And then you can see the estimated disease burden based on the Cleerly AI CAD-RAT scoring with 20%, 50% or greater stenosis, and about 10%, 70% greater stenosis. Now, part of us at our group adopting some new technology is to earn confidence from our readers. We have 7 experienced readers at the time that we did this from a multitude of dual source scanners. And I would say that the group has a history of being somewhat skeptical towards new technologies. Thank you. So what we did is for the first 2 months of 2023, and then we repeated it again this year, we really just read our scans the way we typically would and report it, and do not reference the Cleerly results. And then I did a retrospective look at what did the Cleerly results produce compared to what our clinical reads were. So these were essentially blinded. And you can see what happened is we noticed using CAD-RATs, we would have perfect agreement about 60% of the time. That's actually very good in my view, because it's hard to get readers to agree with each other, and there are a lot of borderline cases. And then I think what really clinched it for us in terms of having confidence using this is that when our readers felt like we're looking at non-obstructive disease, with no selection and with no editing, Cleerly agreed with our readers 95% of the time. And only 4% of the time was there a CAD-RATS difference grade of greater than 1. So with that, even though we think stenosis is just a small part of the picture, it is a big thing in terms of us getting more confident with the information. So with that, I'll present just a couple of cases here. Now, this first one is a patient that's a referral from a general practitioner. A 69-year-old man who's generally healthy, had dyslipidemia, and some chest pressure sensations that had resolved after a normal stress echo 2 years ago. He's taking no prescription medications, and you can see his lipid profile there. On the strength of him being 69 years old and a man, his ASCVD estimator puts him at 16% risk of major event in the next 10 years. And he requested coronary evaluation, was referred for coronary CTA. On the top left, you can see that his calcium score is 77. But I think it's fairly obvious that he has pretty noticeable plaque in the proximal left ventricular descending artery. And I'm going to put this into the Cleerly display, which straightens out the arteries. And the next thing I will do is overlay the plaque on it. And I will do that again just so that you can see. And this is pretty typical for our experience, which is wherever on the display my eyes are seeing the plaque, when I put the plaque overlays the areas that I see the plaque. So, another sort of compatibility between what we're seeing and what our own impression is clinically. And when that all is quantified, this man has a total plaque volume of 651 millimeters cubed and a percent atheroma volume of 17%. And on the bottom right there, I showed you that most of the plaque comes from his LAD and RCA. So summary here, calcium score of 77, which would have put him in a certain potential category of risk, coming in with an ASCVD estimated risk of 16%. And then he's got these percent abdominal volume and total plaque volume numbers. So I think one of the things that we ended up driving towards after having routine access to non-calcified plaque and total plaque volume numbers is, I think we kind of completed the circle on our reservations on creating a group of patients who are considered highest risk. And so, when we get a calcium score, we don't see degree stenosis. We always think about, what are we missing with non-calcified plaque? But now, with the Amsterdam data that came out last year, we have this percent atheroma volume that includes both calcified and non-calcified plaque. So at our location with this, we've created this high-risk category with the thresholds there described, and it's any of those four, with the top three we think being an extremely high category of risk. This patient was started on aspirin and rosuvastatin, and this brings us to another thing that we're now trying to address, which is what do we do with these identified very high-risk patients who probably exceed the typical ASCVD of just greater than 20%. And what should we tackle with that person? Are we going to go to other aspects, not just medication? Are we thinking about nutrition? Are we thinking about sleep? Are we thinking about exercise? Something more where we're hounding the patient a little more besides just medications. So that's something that we're now working towards. Second patient, 79-year-old man with the risk factors there. He's got chronic obstructive lung disease, and that has been out. He's been out of breath more than usual for a year, and has just not improved with bronchodilator therapy, and there are his cardiac medicines you see. He's referred for coronary CTA, and there are a couple of CAD-RATS 3 lesions in his LAD. Calcium score is 996 there on the bottom left. Here we go is a display of his plaque, and then here's the Cleerly AI detected plaque overlay, again, really just right where my eyes would train towards the predominant amount of his plaque. And in this patient who's symptomatic, we ran the ischemia tool on him. And in the LAD there, you can see that the AI read was indeed in CAD-RATS 3, and that vessel looked like it's likely to be ischemic based on the AI. So because of his symptoms, he was referred for catheter angiography. And the first two that's playing here is just displaying this long area of moderate-looking stenosis in him. And when a adenosine FFR was done with a pressure wire, he had a pretty focal decrease in FFR to 0.77. So that whole region was actually treated with a drug-eluting stent with a post-procedural FFR of 0.9. In a month, he said, I'm breathing better, and this is different than the way I felt a year ago. So our accumulated experience with the ischemia tool, which we used also unselected for the first 3 months of this year, is, I'm summarizing it here, 663 patients. As of last month, 52 went to invasive angiography. Of those, 44 were ischemia positive. Invasive angiography and CTA reads, again, were all blinded to ischemia results. And 35 of them turned out to be flow limiting either by flow wire measurements, or they had just outright very severe stenosis on angiography. And then on the bottom there, so far we've found that when our readers are reading CAD-RATS 2 or 3, that is when the ischemia tool is most likely to affect our management decisions. So we're going to continue with this, right, with Yader next.
All right, thanks so much, Victor. I think that you highlighted a lot of great things. We typically trichotomize things. We'll do nothing. We'll treat with medical therapy. we'll send somebody to the cath lab. In each one of those categories, there's so much depth and nuance. I'd like to introduce Dr. Yader Sandoval. He is an interventional cardiologist from Minneapolis Heart. He and Victor are colleagues, and he has really been one of the few pioneers that have been pushing this this concept forward of using CT for intervention. And I think that he'll show some cases here that really goes into how nuanced and thoughtful CT can help, and in particular, clearly for help guiding interventional decisions. So, Yader.
Thank you, Jim, and thank you for the organizers for the opportunity. Well, hopefully we can remain awake here after lunch. I really have no Kaplan-Meiers to show you. This is going to be very practical. So, again, I'm an interventional cardiologist, and the question is, why are we using this? We have so much data from intravascular imaging, right? IVUS, OCT, that this improves outcomes. And of course, the question is, naturally now, with improved hardware, with improved software, can we just use the information from CT to better plan our procedures? Something, I'll go into the slides, but I've made a couple of notes so we were going through the talks that I think it's important to underscore is that why did we start using this? And I think the issue of ease of access is critical, right? Like, I don't have access to the fancy CT software at home, but I can open this in my laptop from the cloud at the convenience of my home and plan my entire procedure before the next day. So that's something very unique. Remember that, again, for us interventionalists, we used to go to the basement, where's the radiologist or the imagers to help me with this. Now I can look at this from the convenience of my home, and I think that's an important issue of access. So is this a totally radical concept? Who would do a TAVR without a CT? Nobody, right? For some reason in PCI, we have not yet incorporated that concept. We still have this idea that your CT is a diagnostic test, you had CAD, you're gonna come to the cath lab, and we're gonna figure out in the cath lab. We're gonna wing it and figure out what's happening. But the reality is that with CT, now we can better allocate and triage and plan our procedures. What we like to talk about is where, who, when, and what. So if we really look at the CT, not from a diagnostic perspective of the gatekeeper of the cath lab, but no, you have disease and we're gonna figure out how to best take care of you, you can see that on the patient on the left, there's a patient with focal coronary artery disease, no significant calcium, and this patient can be done by anywhere, anyone, at any time. So this is a super straightforward case, right? But if you look at the CT and see on the right, there's tremendous amount of calcification all the way to the ostium. You can allocate this case to your mothership, to a chip operator with the right equipment. This is something that we as interventionalists and your colleagues in the cath lab, we have not really been looking at because we have not been thinking of the test as a therapeutic test, but we have historically used it only as a diagnostic test. You can see there's a lot of opportunities. There's a lot of lessons from intravascular imaging that all of us are already familiar in the cath lab. When we look at IVUS and OCT, we have already standardized that there's a lot of information with all these modalities, whether it's CT, IVUS, OCT, physiology, but we already know that the things that we care about are morphology, length, and diameter. MLD people refer it to. This has been validated with intravascular imaging. And therefore, as shown here now to incorporate with this CT is, well, we can just pull all this information from CT, therefore. And as you can see, you look at the morphology, you can look at the calcium, you can do colorization based on Hounsfield units, understand where the calcific plaque is, you can look at length. I'll show you how you can look at this with CTOs, you can look at diameters from lumen. So you can pretty much apply all these lessons and now use them for intravascular, with coronary CT. So how do we do this? Victor showed a little bit of this, but I really want to emphasize this a little bit further is that, again, what I think approaches like this one from Cleerly really bring is that they level the field. I no longer need to be, particularly for us in the cath lab, I don't need to be a level 3 CT reader to get this information. This democratizes the information from CT from everybody else, including the imagers. So I can just go to a view like this, and the 2x2 square as shown here nicely tells me the problem is in the LAD. I like the 2x2 table actually quite a bit, and it tells you it's a 74% stenosis per AIQCT. And if you want to do a quick overview, you can just scroll through the straight NPR as shown on the right. But this is what the view of what you can do here with an MLD approach and for intervention. This is like in one page how you can bring all this information and in one page pretty much plan your procedure. You can go to the axial view, and I'll show this in the next video how to do it, but you can go to the axial view and understand where's the ostium of the vessel. And therefore, you can understand what guide do you need. You can look at the multiplanar reconstruction, whether it's straight or curvilinear, and understand where the lesion is. Is there a branch coming off? And that will influence your revascularization strategy. For us, that we're interventionalists, we're not looking at all this all the time. You may want to look at the 3D model as shown there, and it'll give you a nice ring to understand where exactly you are if you're confused. And again, as you can see, you can get a sense of what's the lesion length. And then, of course, critically, I do want to show on the right, this issue of plaque and calcium is critical in the cath lab. So if you can easily, pre-procedure, understand whether the lesion is calcific or not, that's incredibly valuable information. So as you can see, if you put all this information in a package, you know what you're dealing with. This is a non-complex lesion, focal middle AD. Any operator can do this in any cath lab. You know you need an AL1 guide because it's an anterior takeoff of the right. You know what you need for the left. You just need a balloon. You don't need a atherectomy or IVL. You know you want to avoid the diagonal. You need probably a 15-millimeter stent. So you can pretty much have your whole package. We have not been thinking about this in the cath lab historically, and there's clearly opportunities. I don't want to take too much time, but I do want to show how to do this because as you can see in this whole video, you can go step by step and show how you can integrate the whole approach. So you select your vessel of interest. Again, you can go to the axial view and pretty much just scroll through this, see where the left corner is coming off. The way we use this for interventional is because I want to know, well, how dilated is that aorta? Do I need an XB35? Do I need an XB4? What sort of guide do I need for the left system? Is there a different takeoff? As you can see here, the right's a little bit potentially a little bit anterior, not too bad, but again, you can get a sense of that, and that saves radiation and contrast in the cath lab because you know what equipment you want. Then you can switch here to the straight or curvilinear MPR, and you know the problem is in the LAD because you get this from the model or from the 2x2 table. You can just rotate and see, all right, that's where the LAD problem is. And again, you can therefore scroll through the cross section and see nicely where that lesion is, and you can see that the 3D model, the cross section moves along with a 3D model with a red ring. So again, you get a lot of information, very, very ease of use. Something that's important, this is all automated segmentation, right? So for those of us that are not level 3 readers or imagers, this is already segmented, which makes it very easy. You can see the 3D model with the lesion right where the red ring is. Something that I think is going to skip here, hopefully in a second, is right there. As you can see on the left, you can pretty much then press on the plaque button, and I do want to underscore that at present and moving forward, the issue of calcium is critical. There's a lot of heterogeneity in the cath labs across the country. There are non-surgical backup labs, there are ASCs, there are hospital-based labs, and we have a lot of atherectomy modalities. So if we can better understand where the calcium is, as shown here, that can really, really help us understand how to better take care of these patients. This is this case that I'm showing, focal middle AD as predicted. We use all the information from the CT, and as shown here on the right, this patient goes as planned by the CT guidance at 2.75 by 15 stent. A couple of concepts that I want to mention to wrap up. I've already underscored the importance of calcium. If you understand that calcium is the problem, you can better allocate this to whoever is your high complex operator that deals with calcium. So at the right place, at the right time with the right operator. Again, this is this patient that went intravascular lithotripsy because of lesion with severe calcification. The other thing that I think is quite unique is the issue of CTO PCI. Of all the things of interventional, there's actually a randomized trial that's showing that if you use CT to plan your CTOs, you improve procedural success. So there's a lot of things that sometimes we don't necessarily have robust data. For CTO, we do have a randomized trial. The issue is that, again, getting that information was hard to get at. But now, as you can see here, with a platform like this, you just pretty much go, click the CTO button, automatically identifies where the CTO is. It's in the shaded area. You can measure the length, so you already know where is your CTO. If it is, how long is it? You can see whether there's calcium at the CTO. You can see whether there's any branches coming off it, so you can get a lot of information. So to wrap it up, I think that as it's done for TAVR, we need to shift our mindset to use CT for PCI guidance. This can really help with pre-procedural planning, and I think you're going to hear more about this no doubt coming forward into the future. This is something that us in the interventional community are opening our eyes to the opportunities. You guys have been seeing this every day. Us in the CAD lab, we haven't. And there's clearly opportunities for partnership. We do this in our lab because I have people like Victor, Joao, I see him over there, Jonathan Auerbach, our colleagues that support us in the CAD lab to do this work. And if you have interventional colleagues that you think should be aware of these emerging opportunities, we're educating them on October 24th and 25th. Thank you so much.
Yader, thank you very much. Look, we've got a few minutes. I'm going to try to walk back from Yader's talk back to Maros's talk. But, the one thing is that I think that the last thing that he left us with, which is that the interventionists and the non-invasive imagers have to start talking more together. Because I think what he described to you, you'll see over the next few years, will become a new paradigm of care, where we're actually going to use non-invasive imaging to help guide what they do in the cath lab. So can I just get a raise of hands? How many interventional cardiologists are there here? So there's a handful. How many of you know the FAME and FAME2 trials? A fair amount. I'm just going to start reading off a couple of other trials, like Ultimate, Octavus, Guide DES, Flavor, Renovate, Complex, Prevent. So there's more data for IVUS-guided PCI to improve patient outcomes than there is FFR-guided PCI. The most successful outcomes trial was Prevent, and Prevent did something special. What they did was fuse two pieces of information. So it was OCT guided and it was near field infrared spectroscopy guided. So you had lipid-rich plaque and you had vascular morphology, and there were sustained benefits and improved outcomes at 2 years out to 7 years. So we are entering into a new era where coronary disease is not that simple anymore. It's not just, do you have a stenosis or not, or do you have something, above or below. It's going to be really examining that lesion with all of the tools that we have, and I think that Yader and his team are really leading that field, so congratulations to you. I think if you step back to what Victor was saying, I think what I kept thinking about through Victor's cases is this concept of residual risk, right? So you put somebody on a statin, you have a 20% relative risk reduction, that sounds great. That means 80% of the people, you've lowered their cholesterol, you put them on a statin, they didn't benefit. Who are those people? I don't know who those people are because the LDL is already low, right? And so now if we have plaque phenotype and quantity, now all of a sudden we have a measurable tool to figure out who are those majority of those people who aren't benefiting from the medications. It also gives us an example, like Victor alluded, he's like, well, how would you treat this person? Well, if I hear one more time, I put them on a statin, what else can I do? I will pull out my hair. There's at least 14 different medications that we can use for prevention. And not only the GLP-1s and the PCSK9 inhibitors, but all the stuff that's coming out, right? The LP-little-a lowering drugs, anti-IL-6 drugs, there's just so much in our armamentarium. So the way I look at sort of the Cleerly platform is that the imaging defines who should be treated and how intensively, and all of those laboratory tests that we use help us figure out how to treat somebody, whether medically, whether with lifestyle interventions, or whether in the cath lab or not. And then when I come back to what Maros was saying, I think that we've spent a fair amount of time trying to develop good evidence, not only diagnostic performance evidence, but cardiovascular outcomes evidence. We are committed as a field to try to continue to grow that evidence. I see my colleague Udo Hoffman over there, he has now, he's leading a large 40 site, now maybe it's a 50 site global registry with 4-year outcomes called Confirm2, and is now leading at least 3 randomized controlled trials. So we're committed to continuing the evidence generation, but I just want to thank the speakers because I thought they did a great job. Let me just see if there's any questions for the audience, just to wrap us up. Or from our speakers.
Looks like it's clear.
All right, on that note then, I'll thank you for your attendance and I'll wish you a good meeting.